Can y'all hear me? Good deal. Good afternoon and welcome to the 2016 Hayes Watkins Lecture. My name is Cody Cox and I am the chairman of the Dean Student Advisory Council. The Dean Student Advisory Council is a group of student leaders from the student organizations in the Gordon Ford College of Business that help the dean put on events such as this one. On behalf of the council, we are so pleased to have you all here and hope you can join us for the reception to follow at the Alumni Center starting at 4:30. Now, I would like to introduce a very good friend of mine. Dr. Jeff Katz is completing his 5th year as the Dean of Western Kentucky University's Gordon Ford College of Business. He is a full professor of management and former Fulbright scholar whose teaching and research focus on global competitors, strategic decision-making, and corporate governance. Dr. Katz obtained his doctorate from the University of Florida's Warrington College of Business Administration. He is currently the president of Mid-American Business Deans Association and past president of the Midwest Academy of Management. He currently serves on the International Board of Governors for Beta Gamma Sigma, the premier honor society recognizing business excellence. Ladies and gentlemen, please join me in welcoming the Dean of the Gordon Ford College of Business, Dr. Jeff Katz.
Well, thank you. Mr. Cody Cox, give him a hand, please, would you? Cody serves as chair of the Student Advisory Council. They do a fantastic job helping us lead the Gordon Ford College of Business. And we have our business ambassadors here, too. Council members and ambassadors, are you here? Would you raise your hand or stand up? I know we have a bunch around. Thank you for your service. Give them a hand, would you? Thank you for being here. We are delighted to have a special program for you this afternoon, including a reception at 4:30 in the Alumni Center. Our speaker today, Mr. Carl Whitmer, will provide us some guidance and ideas about leading the way in the rapidly changing healthcare industry. First, however, I'd like to recognize a few individuals that took the time to be here today. First, I'd like to recognize here with us Carl's terrific wife, Beth, in the front row. Beth, hello, and thank you for being here. Mr. Whitmer travels quite a bit, and she supports his work, as he'll talk about. His parents are here too, his folks. Mr. and Mrs. Whitmer are here in the front row. Glad to have you. Give them a hand, would you please? Our college is also led by our Executive Advisory Council. We have some of those individuals here, including some have come from Washington, D.C. to join us today. Our council chair is with Mr. Chad Davis. Chad, would you stand to be recognized? Other council members here with us are Mr. Ron Sowell. Ron is here. We have Mr. Dick Gladden is here, and Dr. Randy Capps is here. So thank you all for coming and joining us for this event. We have, I think, the best leadership team of any college of business in the country today. I proudly call us the best applied college of business in the Commonwealth of Kentucky. Our faculty and leadership of the college are a part of that, so are our students. So first, the leadership team of the Gordon Ford College of Business, would you stand to be recognized? I know that Dr. Blankenship is there, our leadership team. They are the dream team, so they're here for you. Our 9 undergraduate programs and 3 graduate programs are led by our faculty leadership team. Our faculty are here as well. With our faculty of the Gordon Ford College, please stand and be recognized. I know we have faculty members here. There they are. The best I've ever worked with. They do a tremendous job in the classroom, in their research, and in helping in the community as well. My good friend and colleague from the College of Health and Human Services is here today, Dr. Dean Neil Chumbler. So Dean Chumbler, please stand to be recognized, please. You know, when we identified Mr. Whitmer as our premier speaker, we were excited because first, he's a hilltopper, as is his wife, Beth. Second, he has been on the national stage of the healthcare industry, which today is a very important industry to understand, particularly for baby boomers like ourselves thinking about the need of healthcare in the future, and for all of you about potential jobs in a growing industry throughout this world, really. He serves on the Accounting Advisory Council. He's a graduate of the accounting program and has risen consistently through his career to levels of impressive success. Mr. Carl Whitmer serves as the CEO of IASIS Healthcare, and he's been in that position since 2010. He provides strategic vision, leadership, and oversight that enables the company to further its mission and provide high-quality, cost-effective healthcare services to the many communities that firm serves. It's an impressive company with revenues in excess of $3 billion, 13,000 employees in the organizations that are part of it, and it serves 628,000 individuals that receive health care from it in a whole variety of ways, whether they be the 17 acute care hospitals, the behavioral hospital they operate, 141 physician clinics, and many other outpatient organizations. He truly is on the national stage representing the healthcare industry in Washington, D.C., and also comes home to Western Kentucky University to share his comments with us. Please give a happy Hilltopper welcome to Mr. Carl Whitmer.
Can you hear me in the back? There we go. It's on. Well, thank you. Thank you so much, Dean Katz, for such a nice introduction. It's fun to come home to Bowling Green. We don't get to do that very often, and to see the changes in the campus are quite amazing. It's been a number of years, as Dean Katz said. I graduated in 1986 with an accounting major, and some of you won't remember some of the names. Dr. Wells will, but Dr. Hall and Dr. Hayes and many others in the accounting program. And I walked back upstairs on the 5th floor a moment ago, and those offices haven't changed, right? They're the same offices they were in 1986. And I think I've been on my knees in a couple of those offices before as well. Accounting 301 about brought me to the floor, I think, at times. So but it's fun to come back, and it's fun to spend some time with you. I'm often speaking about the healthcare industry in a number of different forums and venues. And so last week, I have a son who's in a graduate program in San Antonio, Texas, and Trinity University, and I spoke to that class, and after a few minutes, got into it a little bit and got a little bit excited. We were talking about a lot of different ideas. I could see my son in the back doing this, saying it's time to go. So if I go on too long or I get too boring, I certainly will look in the back this way, and someone can give me the hook if you like. Listen, healthcare is, there's a lot going on in the business and in the industry, and it's so important to each and every one of us. It is a bit surreal to be up here, to come back to, when I was in your chair. I wouldn't have thought I'd have been at this lectern back in the late 80s, I'll call it. So it is really interesting how you can start from where you're sitting today and think forward and think about the different ways your career will lead you. I started in public accounting. I spent about 8 years there. Then I went into a physician practice management business and found my way into the hospital management business and managed care industry. It's been very rewarding. The best thing we get to do, I'm not a clinician, obviously, having graduated from the Gordon Ford College of Business, but the best thing we get to do is impact people's lives. How do we touch people's lives? And the thing I think I can bring to that oftentimes is what kind of business sense can you bring to the table to try to navigate a really difficult environment from time to time. The other thing I would tell you is it's just about having passion about what you do. You've got to, whatever you do from the various majors represented here today in both colleges and elsewhere, it's about having a passion for what you do and really living that out in terms of your focus and your vision. And believe me, every step you take won't be your last. There'll be ups, there'll be downs, there'll be a step in a career progression in one direction, and sometimes you might take another. And that's certainly what's happened to me. I appreciate Dean Katz recognizing some of my family and friends here, but in terms of the Hilltoppers, I do want to just go back for a minute. My dad's a 63 graduate. I guess back then it was called the Business University BU back then, and so I appreciate him being there. My mom, my late mom was, and my stepmom's here today, she was a 64 graduate from Hart County. Dad's from Muhlenberg County. I lived in Owensboro for a period of time, and then we moved to Portland, Tennessee, I don't know, when I was in elementary school. So we've always been around Western. My wife, graduate of Western. My sister was an education major, and so it's been very important to us over the years. East Hall, what is now called Northeast, is certainly a little different, and maybe in some ways it's not so different either than when it was when I started here. Lived in Douglas Keene Hall, lived on campus 4 years. I know everyone can sigh of anxiety over that. I'm waiting to hear it, but I did, and so it was a great experience. I've met one of the football players here a moment ago, and certainly the football program wasn't at the level it is now, and so I really enjoyed the success and watching the team's success this year, and got to see them play a couple times, so it's been good. But Western's been a family thing for us, and it's been important to my development in my career, and I couldn't encourage you any more to really take a moment and pause when you hear, those of you in the graduate program, those of you who are soon to wrap up, about things go on here at the Hill and how you can reflect back on that as you leave the campus. What I thought we would do is, healthcare can be a little complicated, and I speak to a lot of people, a lot of Wall Street folks, and you know what, most of them aren't much older than you. They've just been out of school a couple years longer. But they tend to be focused on the industry, and they tend to have an idea of what's going on. The thing about healthcare, for those of you in the business college and also and in the other colleges that are here today, it is something that touches everyone's lives, and it is something that's going through tremendous and rapid change. It is about a mission of caring for people, as I said a moment ago, and we'll skip through that. And I think sometimes it's helpful for you to understand kind of my perspective and where I'm coming from. Dean Katz mentioned a moment ago, and what I hope to do today is start out giving you a perspective of the business that I run, the business that I'm a part of, the team that I have around me. Then we're going to talk some about the industry in general and what's happening in the industry, the evolution that it finds itself in. And then we'll wrap up, and I'll talk a little bit about the way we're doing things inside our company to try to adapt to the changes going on in the industry. But healthcare involves everyone. It involves you. I know you're young now, and most of you don't engage with the system a lot, but I suspect your parents do. And you're going to be looked upon 5 years from now, 10 years from now, 20 years from now, to help parents or other loved ones and family members kind of navigate the system. So I think a lot of this will be helpful. As Dean Katz mentioned a moment ago, I want to be sure you get my perspective, because when I speak to people, I want you to understand from where I come from within the industry. As I said, I was in the public accounting business for about 8 years with KPMG, went to the physician practice management business, and now with IASIS Healthcare. We have 18 hospitals. We're operating in 8 states. We're headquartered down in Nashville. As the dean said, we have about 13,000 employees, somewhere around 3,600 physicians on our medical staff. We're treating over 1 million patients a year in our hospitals. We have about 640,000, it continues to grow each month, managed care lives. So what's different about our company is that we're not only a provider of healthcare services through physicians and hospitals and other kinds of ancillary centers, but we're also a managed care company where we're managing the care. And so we do that under a brand called Health Choice. And think of Health Choice as a United Healthcare, a small United Healthcare, or a small Humana, or Anthem, some of the companies you may be familiar with, but very small. What it's allowed us to do, we kind of look at the world through the managed care lens, where we're thinking about how do we manage the cost of care, and then we're also thinking about the world through the lens of a physician and a hospital, and how do we provide that care. And in an environment that we're in, you all hear a lot about the cost of care, and we hear a lot about this presidential election, and we hear the Democrats saying, you know, everything for the Affordable Care Act, and we hear the Republicans saying we're going to repeal and replace. By the way, which no one has really completely defined, right? So we don't know what that means. I also watch closely while I live in most of the time in Tennessee. I travel every week. I've watched not close, but I have kept abreast of the governor's view on the Kentucky Medicaid expansion, and we'll talk about that in just a moment. But we happen to be in some great states. Someone came in and was introduced to me a moment ago from West Monroe, Louisiana. We're in West Monroe. We're in Texas. We have 5 hospitals in Texas. We have 4 hospitals in Phoenix, Arizona, 5 hospitals in Salt Lake City, Utah. We stretch across the state line and get into Hope, Arkansas, which again is the home of former President Bill Clinton, and have a small facility there. And then we have one in Colorado as well. So we also get the perspective of working across the country and understanding people's different views as you move from a market to market to market. The other thing I would tell you about healthcare, and you look at our map, is that all healthcare is local. The great work that's done here by the clinic, the hospitals, the other independent physicians here in Bowling Green, Grails Gilbert, and the rest of the docs that are here, that's really important work. And every strategy, every business, most business decisions that are made about healthcare have to start at the local level and make their way up. We can't make broad decisions at the top and push them down. There's certain things we do. Many of you will have some connection or work in information systems and things that I would call core services that we do commonly across our platform, but the strategies are all very different. Let me move on for a minute to the industry in general. And there's so much that can be said here when you look at this particular chart. And a lot of times people talk about how much we spend in this country on healthcare. And we do spend, I know it's hard for you to see up there, but we do spend more than other developed countries across the world. And some would argue that while we spend more than the other developed countries, our outcomes are no better. And what I would tell you is, I'm sure I can't argue the numbers, I'm sure much of that is true. What I can tell you is, though, it's also an expectation, a cultural expectation, a gift that we have in this country in terms of what we expect. When you think about the advances in drug technology, there's now a cure for hepatitis C. It gets all kinds of press, in terms of its cost. And I will tell you, from a hospital operator's perspective, pharma is really, really expensive, and in the advances that we have in pharmaceuticals. And you're hearing things, today where you've got CEOs that have to go to Capitol Hill to testify about their pricing and things of this nature. But we expect as a country significant advancements in technology, CTs, MRs, all of you, many of you, I'm sure, have had those kinds of procedures in the past, but it's expensive. And there's a cultural issue in our country, not an issue, but a cultural expectation with respect to the kind of care that we want and the way we want to engage in a healthcare system. So it's true. It is expensive. It's also true that it's up to 16, 17% of the gross domestic product. So along about 2009, 2008, when President Obama was elected, and we passed the Affordable Care Act under, a very strained and stressed system, the idea there was to do a couple things. I'm sure some of you have heard some about that. What the Affordable Care Act is trying to do is get more people covered. We were to the point where we had 45 million people in the country who didn't have insurance, didn't have access to insurance. Now keep in mind, hospitals are going to treat you regardless. I mean, not only is it federal law that if you show up and you're in an emergent condition, we're going to treat you regardless of your ability to pay, but it's also our mission. It's what we want to do. But keep in mind that as you think about that. But we had 45 million people in the system without insurance, but who were accessing the system. They were going into the system for care. And so the number kept getting bigger and bigger, and so the government's sitting there thinking, okay, what do we do? Because what happens is, for those people that do pay for their care, there's a lot of cross-subsidization that goes on because the numbers were growing in the country for those people that didn't have it. The other thing I would tell you is that I believe through the managed Medicaid organization that we have inside our company called Health Choice, that if we can get people access to primary care physicians, we can get people access to prescription drugs, we can keep people on prescription drugs, we can keep people going to see their primary care physician. Over the long term, we're going to bend that cost curve. Over the long term, the cost that this country is experiencing should come down. Now look, a lot of this is politicized, and it's politicized in so many different ways. It's been a topic of national interest all along. But as this has happened, as this has taken place, the costs were growing at an unsustainable rate. When you start getting to 18% of gross domestic product that your country's spending on health care, and you think up here some of the other numbers it's showing, 6% on education of GDP, 3 on military, 2 on infrastructure, it has to be dealt with in some way. And so the Affordable Care Act was an effort to really try to do that. As you look in terms of spending, this chart represents, and I don't want to get overly technical about it, but I will a little bit. You ever heard of the 80-20 rule? How many times have your parents talked about the 80-20 rule? So what happens in healthcare is oftentimes 20% of the people using healthcare are 80% of the cost. Why is that? It's because we treat end-of-life care in this country a little different than maybe some other countries do. It's because chronic conditions soak up so much of the system that a lot of the costs go there. And so there's a lot of things that have got to happen over the long term to change, to bend this cost curve that I talk about. And this growth rate in healthcare at 18% of GDP, many would argue, is unsustainable. So when you look at the Affordable Care Act and the chart that you see up there now, the growth rates were going at 5, 6, 7, 8% a year. The Affordable Care Act was passed. The national growth rate in spending dropped to about 4%. There's still $3 trillion a year spent on health care in this country. It's a huge number. And now you see the cost of that care beginning to rise just a little bit again. But there's a lot of different factors for that, and lives are being improved as a result of it. That being said, we still have to wrestle with the cost. Here's another reason that this continues to happen, and a little bit off topic from the chart. Every 24 hours, there's another 10,000 people going in the Medicare program. Think about that. So you think about your generation and the number of you that are there that are going to be paying taxes, and you think about every 24 hours, there's another 10,000 people going into the Medicare program. CMS, which is another name, the Center CMS, another name for Medicare. When you hear me talk about Medicare, it's interchangeable. They say they'll spend $10,000 per beneficiary per year for care for those of you who have grandparents and so forth in the Medicare program. And now for a person just now entering into Medicare, the actuaries say that they'll spend $450,000 on an average Medicare enrollee over their lifespan from the time they become Medicare eligible until the time they pass away. Those are big numbers. So we have an aging of the population. You all are going to get to help pay for my Medicare when I get there, right? I'm kidding. Look, the program is going to have to change over time. And as you all mature and grow in your careers, you're certainly going to have to help navigate the change that's going to need to take place. But what's happening as you look at this chart is the red is the number of Medicare patients in the country. The gray is the number of what I'll call commercial pay patients, the traditional managed care patients. So you work somewhere, you get an insurance card, a blue card, an Anthem card, you're in that gray part of the chart. Those of you in the Medicare program, you're in the red part of that chart. And look what's growing and look what's shrinking. And so when you just start thinking about this and you start putting together, you say, okay, so we know the older you get, the more expensive you are. We know that there are 10,000 people a day every 24 hours going into the Medicare program. We know that hospitals operate, and this is a national number published by CMS, hospitals operate at negative margins on Medicare business. So I've got a slide here, I think, coming up in a moment, and I'll get to it. But hospitals operate at a negative margin. You start putting all this together, and you got to say, okay, how do we get at this differently? What are we going to have to do differently in the system to make this work? And you look at the key demand, or this is the growth rate. You see 7% plus compounded annual growth rate, 5 on the Medicaid side. There's 56 million people or so in Medicare now. There's about 75 million people in Medicaid. And certainly those programs are growing as a result of what we have going on. But here's when you think about demand and the key demand or drivers of demand, if you will, you do a couple things. There's got to be a huge government influence. That's on the left side of the chart for you all. A huge amount of government influence going on in the marketplace where the government is now responsible for more and more of the care. The government is funding more and more of the health care that goes on in the country. Certainly, I'm not an advocate of a single-payer system. I think there needs to be competition in the marketplace. I don't think that would be the right solution. That being said, just by the virtue of the kinds of programs we have in the country, the government is a bigger and bigger influence in terms of what's going on. And I would say this, is that every day you'll hear people, you just heard me make a comment about pharma, didn't you? Did you take that as somewhat negative toward pharma? Well, look, it's expensive. And you're running a hospital and pharma's very expensive and their prices are very high. But what you see a lot in the industry, you'll say the device manufacturers, our margins are too high. The pharma margins are too low. The hospital people will say the hospital margins are too low. How do we kind of bring all that together? And I will tell you that there is change taking place in the country that over time should allow these parties to work better together, in theory, and collaborate more, particularly with hospitals and physicians, to try to reduce the total cost of care. But I would also argue that everyone has a role. Everyone has a role. It's you as individuals, it's you as caretakers for your parents. At some point, the country's got to wrestle with how do we accept maybe doing things a little differently. So to give you a common idea or a common theme like that. How many times have you gotten your insurance card at home and you look through it or the booklet, or you go online? I'm old school because I'm talking about a booklet, but you go online and you're looking, okay, is my doctor in this panel? Is my doctor in this group that I can now access through this insurance card? And we've gone through a period of time. I get back to what our country expects. We want open access to the system. Here's a question for you. If you think your knee hurts, do you think you should go straight to the orthopedic surgeon, or should you go see your primary care physician first? What do you think? Because when you access the system at the wrong points in the wrong places, it costs the system more. And it's sometimes not something that we want to hear or we want to deal with, because I'm like you, I want the best care I can go get. and I want to go to the best doctor I can go find. And look, it is a cultural, it is an industry, is a clinical issue that we'll wrestle with for the next several years, but it's very important to think about how we all have a role. And I would argue that what's happening is, in the country, is this push for value. So now we'll talk business for just a minute. So all of you now in business school, you've had the P&L, you know about the balance sheets and so forth. So when you think about, let's pick on ourselves for a moment, a hospital. How do we get paid today? We get paid when someone comes in and encounters the system. So think of it, if you go in and you have a test, lab test, an MRI scan, a CT scan, we get paid. You have to go back and do something else, the hospital gets paid. That's called a fee-for-service system. Okay, so think fee-for-service. You're hearing about it more and more if you're just watching the news at all. And I think what's happening and what we see happening across the country is this idea of we're pushing more to value. We're pushing more to value. And what I mean by that is we ought to think about more, how then do we get paid on outcomes, and how do we get paid more holistically rather than every time we do something. Now look, this change isn't going to happen overnight. This is a change that will take, a considerable amount of time. But if you think about how the system works, and you think about some of the, I wouldn't call it sacrifices, but I think just the coordination and the collaboration that has to occur over time can help bend the cost curve that the country's been experiencing. And it's this alignment to value, this push to value that's so important. Over on the other side of the coin, drug and medical technology advances. So again, I would use the Hep C example a moment ago. 5 years ago, there was no cure for Hep C. None at all. Today, you can get on a drug regimen, and in a matter of months, in most cases, you can be cured of hepatitis C. Those are wonderful advances. The question's going to be, when you're my age, is how much can the country afford of some of those kinds of advances? And so again, I want us to be able to afford all of those. I want the best technology. And I think what you see those of us in the industry doing is talking about how do we collaborate to be sure that can happen. This is an example of value here. A little bit, I've kind of jumped around, but it's a scale, a trend. And so over on the far left is this idea I talked about a moment ago of fee for service, how we get paid each time we do something. And over at the far right would be the idea of how do we get paid for outcomes and how do we get paid for value. And it doesn't mean that, okay, you got to be careful how you interpret value. It's more about how do we pay one number for an episode of care. Today, if you have a knee replacement, you're probably going to get a bill from the hospital. You're going to get a bill from the physician. You're going to get a bill from the anesthesiologist. You're going to get a bill from the radiologist, because all of those together is what it takes to provide each of us great care. And I would argue that the care that we receive, not only here in Bowling Green but across the country, is the best in the world. So the idea is, how do we think about bundling that? So now we're back into the accounting and the economics of this. So what if we said, okay, let's, instead of paying all those separately, we'll pay one number to a group of doctors and radiologists and anesthesiologists and hospitals that can work together to do it for one number, and therefore try to make the system more efficient as you kind of go through, and also more effective. Because guess what happens today? If we have a Medicare patient today and that Medicare patient is readmitted, the hospital no longer gets paid if you are readmitted within 30 days. If you come into the hospital and you acquire a condition, let's say you're in the hospital and you acquire some other infection, the hospital doesn't get paid for that additional care that is being provided. So a lot of this is changing, and you really don't even realize it as you go through, but it's certainly a movement that is happening. And what's driving that, again, as I spoke to a moment ago, is really those in my generation that are getting so much older, and my parents and others here in the front. It's what's driving it, and you'll be there too. By the way, don't worry. You're on your way. You'll be there. But I would argue it'll be a changed system when you get there, and it'll be changed for the better as you go. This is don't worry too much about the words. Look at the dollar signs for a moment. So this is trying to be a visual for, let's say, congestive heart failure for a patient. And so you have an episode in the hospital. The idea is if you can be discharged home and you can be monitored with telemedicine and some type of new technology that's there in the home health business. I'm sure many of you have had exposure to home health nurses and the home health business. We now can do so much more online, over Wi-Fi, over the web, in terms of monitoring health remotely. And so if you think about that chart up there, the top is trying to say, okay, look, let's say we have an episode in the hospital and it's CHF, and we discharge the patient home, but there was no monitoring of that patient. The patient didn't take his or her prescription drugs. The patient didn't do a follow-up visit. And guess what might happen? That patient gets readmitted to the hospital. Well, what happens then? More money spent because that patient wasn't monitored. More money spent. More money is spent in the system. Now remember, if you're the government and you're thinking, I've gotten down 10,000 people every 24 hours going into the Medicare program, this stuff gets pretty important in terms of how we're going to manage it. And then you go another step, you've got a readmission. You've got to now go see your doctor. And that costs the system money, as opposed to the idea, which I'm sure many of you are experiencing today, you have the encounter in the hospital or the doctor, and you have some type of home monitoring where we can be sure that you're taking your prescription drugs, that you're doing your follow-up visits, that you're holding your head the right way, your knee the right way, you're sleeping the right way in the bed, those kinds of things through home care that then can maybe cause there not to be as many dollar signs in that full episode of care from the time that you encountered the system until the time that you're better or discharged. And that's what we're talking about. We've got in our facility in Phoenix, Arizona, we've got a doctor. He's a great Boston-trained doc, and he does total hip replacement, 23 hours. No overnight stay, a complete new hip, incisions about this long. And he's not the only one. There are other docs across the country, but I'm obviously know who I know, right? And so we go and we even have some of our folks that work with me down in Nashville have gone to him for that same hip procedure. But he discharges those patients home on a minimally invasive type of procedure so as to try to avoid that. And what we've done with that particular physician is this idea of bundling all that up so that we can really be paid for the outcome of that care. So it's an exciting time. It's an exciting time on a number of different fronts. This is what I tried to show you a minute ago. I got a little bit out of line. I am predisposed for a minute because we know how expensive hospital care can be, and it is expensive, and you can't deny that. When you look, though, at what hospitals have, this is CMS's numbers in terms of margins for hospitals versus other providers in the system, not physicians. Physicians are also impacted materially by where Medicare pays. But you can see hospitals have negative margins, and that's back to that point about the cross-subsidization that goes on in the country, which really drives me to this idea of what's going on with the Affordable Care Act, I think, for a minute. And I want to leave some time for some questions too, Dean, as we do this. The political environment is always interesting, right? It's not. I don't know if any of you had fun watching some of this. I've tried to avoid a lot of it as we kind of bantered about, but this thing that everyone likes to refer to as Obamacare has become front and center stage. And if you just step back for a minute and you can depoliticize it, just try not to put on your R, your D in any of this. And I think that everyone's got a seat at the table, and my argument is there needs to be compromise. You can't be too hard left, too hard right about any of this. But if you think about it, the Affordable Care Act's goal was to get more people covered. And if you like the idea that you want to be insured regardless of your health condition, right? And that's what we call guaranteed issuance, and somehow that's got to get paid for. And so what Obamacare did is it said, okay, the country wants guaranteed issuance. The country doesn't want people to be denied health insurance. I think we'd all argue that that's particularly if you have a pre-existing condition that you don't want to be denied. Well, if you're going to have that as a way that we want to exist in this country in terms of our insurance, then somehow that has to get paid for. So the administration's idea was get more people in the system, put more people in the system, back to the 80-20 rule, right? The more people we put in the system that are paying something into the system, the more people the system can cover. And at the heart of it, that was really what was going on with the Affordable Care Act. And it did reduce the uninsured in the country from 45 million to 25 million. I wouldn't say it's all been, fun and games by any means. And I wouldn't say everyone that's engaged in that system has always had a great experience. I wouldn't say that physicians and hospitals totally like the way the system's been put together. But if you step back for a moment and you just think about the things I've talked about, the demand drivers that I spoke to a moment ago, and how we're going to wrestle with those, the core tenets of the idea make sense. The core tenets of getting people covered, because then go back to and again, I won't be clinical for a minute. I'd have to let someone else step up to be clinical. But the idea is that if we can get more people access to care, prescription drugs and so forth, over the long term, we should be able to bend the cost curve for people. And that's what was going on there. There's been a couple of weird twists and turns along the way. Talk about Kentucky for a moment. Kentucky was one of 38 or 39 states that expanded Medicaid in the system. And that was part of what was incumbent, if you will, inside Obamacare to really make it work as intended. But when the Supreme Court decision said, well, we're going to let each state decide, that's made this system very difficult to navigate, because we have a big part of our businesses in Texas. And we know Senator Cruz is running for president out of Texas. And Texas is a state that, unlike Kentucky, hasn't expanded Medicaid. And so what's happened is that we're taking reductions in what we're paid to pay for that expansion, but that expansion isn't taking place. And that's made the system a little bit disjointed. And that's why you hear, and you will continue to hear, I would argue, as you guys graduate from here and you move forward, you're going to continue to hear lots and lots of discussion. And there's going to be tough decisions to be made with respect to health care in the country. I will tell you this, and you're all in the right spot to deal with it. Where there's change, this is a harder thing to say the older you get. You're at the prime spot. But I would tell you this, where there's change, there's opportunity. Value is always created when you can find an inflection point in any system or any business where there's change. If you have to fundamentally change how you're doing your business, there's value to be found in that. And there's value, regardless of your major here in the business college, there's value to be found in that. And you're at the right age, you're at the right point in your career as you move forward, that this is going to be a changing and evolving system. And by the way, a bunch of us are getting older, so we know there's going to be people that need care, right? We know we're going to have physicians, and it's hard to get good physicians. We know we're going to have to do those things, but where you see that change, there's huge opportunity to create value. And so part of this Affordable Care Act was this Medicaid expansion. It was also this marketplace. Again, back to your generation. Think about it. The idea was Amazon for health insurance, right? You got on, you shopped for your health care. Didn't totally work out as perfectly planned, but I would argue that it's gotten better over time. Here's an interesting statistic for you. Our country's so short-term focused so many times. State of Arizona, where we have 4 hospitals, a lot of physicians. We own a big managed care plan in Arizona. That managed care plan does about $1 billion of revenue. Arizona, the Medicare-Medicaid Act was passed about the time I was born, sometime in the mid-60s. I should know that date, but I don't have it committed to memory. The mid-60s. The state of Arizona didn't get in the Medicaid program until 1982. So there's this focus in the country of pass a law, what's the immediate impact, which is important to those of us running a business and to physicians and other caregivers trying to provide care. But there's also this idea that in our country we get very short-term focused. New president, okay, we get in the last year of a presidency, not much happens. But you got to step back and think about some things that have been fundamental in the country have taken a long time to take hold. And some in the room may argue, well, why even have Medicaid and Medicare? Let's just all go to a cash system. That's a whole other discussion that you probably wouldn't want me to come back for, but it's one that we could have one day. What I'll do is I said this a minute ago, and I want to begin to move a little bit toward questions in a moment. I will tell you this, that the mission is what this is about. You have to, it's not just the business of doing what we do. It is also caring about what you do. The most fun I have is when I go in one of the hospitals and I see where our nurses and our docs have delivered a new baby, or where I go in and we've helped someone in some way. And by the way, there's really downtimes too, because it all isn't perfect. It is healthcare, and there's good days and there's bad days, and things can happen in what we do. And it's just all about how you work through those. So the mission is what really counts at the end of the day. And I think important for you all is being passionate about what you want to do. The other thing I would say is that for those of you in the room that are accounting majors and thinking about that, and accounting is a great background, and it gives you a great insight into the numbers. And over the long term, if you think, okay, accounting's not where I want to be, What I would tell you is what you need to focus on is understanding numbers, and the trends of those numbers will serve you well as you think about being able to move in your career the way I have. And you can't do that, again, without relationships, without communication, without bringing the leadership skills that I know you've been taught here at this university, but also at your homes and other places. You can't do any of that successfully without bringing that to the table. Let me talk a little bit about our company and the way we're thinking about this, and it'll tie in a little bit to what I said a moment ago. We are a company that's focused on the communities that we serve. How do we help them live better and healthier lives? And that's what's got to drive. The business side has to support the clinical side. I tell everyone every day, and many of you being the majors that you are, I tell everyone every day, I'm overhead. There's not a thing I do every day, there's nothing I do every day, quite frankly, that is generating $1 of revenue. And what you've got to do is you've got to have the perspective in your mind to say, okay, what is my role inside the company? How am I helping achieve the mission of the company? So the way I try to do that is you try to lead, you try to raise capital, you try to understand the business, you try to understand the industry, you try to bring ideas to the table, and you try to be able to bring dollars through capital that allow you to invest in the business in the way that can try to engage in the strategies we talked about a moment ago. And that's a lot about what our mission is. It's about trying to go into each of these local markets that we're in, and how do we help those communities that we serve live, I should say, better and healthier lives. And so when you step back and you think about the company, the way we've thought about how we put this together, as Dean Katz said a moment ago, we've got these 18 hospitals, we have 144 physician clinics, about 1 million patients a year, 640,000 lives in a managed care business, and I'll talk a little bit about that now. So over on the left side of the chart, think of it as delivery. Think of it as nurses and doctors providing care in a clinic setting, in an ambulatory surgery center, in a hospital. That's the delivery side of the business. That's how we are delivering care. And we're being paid for the care that we deliver today, right, on that side of the business. We treat you, we treat a patient, we get paid. And so that side of the business we call the delivery side. On the other side of the business is what I'll call the risk side of the business. And let's see, I know we have really everyone represented in the college here today, I'm sure. So when you think about the risk side of the business, think about let's just put in your mind for a moment insurance. So the insurance folks don't provide the care. They're not at the bedside with your mom, with your grandparents. They're doing what? They're financing the care. They're financing the care. They're collecting money. They're trying to manage, coordinate that care that the delivery side is providing. We happen in our company to do both of those. And I hope this makes some sense to you. But on the one hand, we're managing and financing the care. On the other, we're providing and delivering the care to the patients that need it. And what we've been focused on, as I said a moment ago, is how do you change the system? How do you change the system where we can coordinate this care in a way that bends the cost curve, right? And the way we've talked about doing that is through something called accountable care. And what we're doing is we're bringing the delivery side of the business together with the managed care side of the business to better coordinate that care. So how many times have you gone to a doctor here, let's say, and you live in Louisville, went to the clinic, you got an x-ray, you didn't get your film, and you go back to Louisville and they're going to do another x-ray, right? The duplication of services that are involved in that. What's that do again? That increases those costs into the system. And so what we want to do is we want to kind of put together a network of doctors, a network of hospitals. We want to put patients in those networks when they're healthy and when they're sick, and we want to coordinate that care in a way that makes it more cost effective. And that's what we're trying to do with our company through something that we call accountable care. And it's been an interesting journey. It's very, very early in the process in terms of where we are along the way. But it's been fun. It's been fun to do. It's been fun to watch. And when you think about, as an example, the Affordable Care Act and what it's asking and pushing people into, it's pushing people into these types of collaborations, these types of partnerships with doctors, with hospitals, with radiologists, anesthesiologists, hospital-based docs, with home care, all of us trying to come together in some way to better manage that care, to do what I pointed to a moment ago, which is to lower the cost of the system over time. But I will tell you though, when you're running the business, it's like standing in the water and you've got your left foot in one canoe and your right foot in another canoe. It's pretty hard to do. Pretty hard to do. It's pretty hard to balance. And I would tell you that we're very, very early in the life cycle of this change. So I hope this is helpful to you in terms of what I see going on. I would tell you, you talk a little bit about the election and what it means for some of you that might be pursuing a healthcare career. I don't think it means a lot in the short term. We know people are growing older. We know that we're going to have care. We know we're going to have to provide more and more care in the country. So I don't think it has immediate short term, but it has really important long term impacts to what could happen to the system. I think that it's going to be important that as we look at it, that we know things can't change on a dime. It's going to take time for many of those things to change. And the one thing that we all hate to hear, and the one thing that was always asked, are you going to take my insurance away? I get it. I get it. We all do. And it's the number one question that we have. And for those people that you say, okay, is Medicare going to be there for me? I think what I'm trying to describe to you today is a way that we change the reimbursement system over time that assures that it'll be there later in life. And again, for those of you that are in the back of the room, where there's change, there's opportunity. And it should be interesting for those of you that want to pursue a career in healthcare. So I hope that's helpful. I've left some time for questions, and I'm happy to do that. I think Cody's got a mic if anyone has one. All right, I put everyone to sleep. Yes?
So, with all this talk about insurance and trying to lower costs and all that, my only beef is that some can argue that one reason costs are going up is because of our reliance on it. Because we have mandatory insurance, we're making it so everyone can afford healthcare no matter how expensive it is. There's no incentive to have competitive prices. There's no incentive to have lower prices besides the insurance list. And plus, with insurance, that's an extra cost on top of everything else in healthcare.
Yeah, I know. I understand your perspective on it. I guess what you're always going to hear me come back to. There should be in there somewhere. It's a great question. I think the question was, if you just step back, particularly for those of you that are young, you're entering into the system, and you're saying, wow, insurance is going to cost me a lot of money, and if I don't buy insurance, right, the way this law works, if I don't buy insurance, then I have a penalty. I think that's part of it. I mean, I know, I don't think it's part of it. And the cost is high. And it's a great question. And you see, I hope, from the numbers that I'm showing, that no matter what, we have to deal with, we have to be able to provide care. We have to deal with the aging of the population. Here's what I would argue is that what it, in my opinion, it tries to do too much. So what if I said to you, there's a more limited plan that you could buy that was for catastrophic type of incidences and maybe some primary care, but then you had more responsibility to pay when you did go. So, finding a balance in that. Because I think, and this is really a technical part of the answer to your question, part of what the Affordable Care Act did is it mirrored the kind of insurance you have to buy on the exchange, on the marketplace, mirrors the typical benefit plan in a geography, in a state. And so it's a pretty comprehensive plan, though it has a really, really big self-pay patient responsibility portion to it. And I can remember, you won't know this, but when I was a kid, we used to buy something called hospitalization. And we didn't have insurance on the doctor's side. We just had insurance if you had a catastrophic event. And I think there's things that can be done, but your question is really important because when I hear a lot of times when I turn on the TV and all I hear is repeal and replace, we never hear what the replace is. We don't know what replace is. We know what is here and what the law is today. And I think what I would argue is it's going to be really hard to unwind that law. Regardless of what we hear, it would take a lot to happen to be able for it to go away. And I'm not trying to be political about whether I'm for it or against it, or I'm for Obama or against, or Cruz or Clinton or whoever. I'm just trying to think about the business at hand. And I think what's going on is that there's compromise in that. I think it can be tweaked in some way that kind of gets at some of the issues that you talk about, because you don't necessarily need it all, right? That gets back to compromise. I would say this from a political standpoint: there's not a lot of compromise that goes on in the country anymore. There's just none. And so finding some of that middle ground that you might work better for you has been pretty elusive in the country in the last, 12 years, going back to when you all were quite young. But it's going to take some of that to make this better. I don't think there's any question.
With technology and research continuing to grow in the healthcare industry, what is some of the most exciting events you hope to see in the near future?
Wow. Technology continues to grow inside the business. I think it will continue to be, I believe, the advancement in robotics. So I was at our hospital in Utah, one of our hospitals in Utah, on Monday, and we walked into the lounge in the operating room, and the surgical team had set up a robotic surgical instrument. And so there was a time when you needed a knee, let's say part of your knee was not working, needed to be replaced. And you would go in and you'd have to have a full knee replacement. Now there's surgical instruments which can go in and just take out the part of the knee that's bad, and we can overlay into that a partial knee replacement. Much less invasive. Those kinds of things are exciting to me. The advancement in drug technology is exciting to me. That being said, if you look at the whole cost of the system, it is an interesting question when you're 65 years old. And the question will be, what are we willing as a country to be able to pay for and afford? And what will happen? Because with this technology comes cost. And I'm for trying to support it every way we can. When you looked at that earlier chart, though, that was up about the difference in cost of healthcare across the world and outcomes, and how we spend more, and generally speaking, our outcomes aren't in some cases any better. When you think about that, and you think about those other countries, there's a limitation to the formulary. And I won't get into countries because I don't want to get too far down this road. But there are a lot of countries who have government-sponsored healthcare systems, and they have a lower cost, and maybe their outcomes are as good, but they don't have the same access to care. They can't get the same drugs. They can't get the same devices. But particularly things on the robotic side, where we can do more minimally invasive work, where we can do with quicker outcomes, I think is really exciting. And then what's happening in the pharma world. Yes. Yeah. The question was, is our company part of an integrated delivery network, and how do we manage this change from fee-for-service to pay-for-quality? You'll hear P for P, pay for performance, P for Q, pay for quality. And we're doing that through that accountable care organization. So what we've done is in Arizona and in Phoenix, Arizona, and Salt Lake City, we've created a new entity, a new business, which is fun. It's always fun when you all get to do this. We call it Health Choice Preferred. And all it is a network of doctors and clinicians and hospitals, ours, who are in a network, who patients like you can go and say, I want that network at that cost. And we have them in that network, and we're trying to keep them in that network so we can manage that care. So that we're paid we're paid a number for the total management of that care. Sometimes, I don't know, some of you in the other club may refer to it as capitation. That's a word that you'll hear. And capitation is, I pay you so much a month for your care, regardless of what care you need. And that's moving from fee-for-service to fee-for-quality or fee-for-value. And we're doing that through Health Choice. What we're doing is pretty unique in that regard, and the way that we have an insurance company inside our business it has been very instrumental in doing that. So that's where we are on our way toward that. Yes? Yeah. Wow, great question. And there's so many. On the business side of it, I think in particular, there are a number of key, what I call entry-level search firms, like Korn Ferry has a practice. I know many of you may have heard of Korn Ferry, and forgive me, you'll have to go back and look, but Korn Ferry has an entry-level practice for the business side of healthcare. I know the individual that runs that. I can't name, it's a subsidiary of Korn Ferry, but that's a great way of doing that. I think that in my case, thinking back through the days, I would kind of search the people I know. And all of you tend to sometimes know a physician or you know a nurse. And I think that local, you can't underestimate just stepping back and thinking about who you know in your network of colleagues and friends to think, okay, who do I know that's in the healthcare business? And then one call leads to another call, because relationships are important. And it doesn't mean you have to know me, but you know, a lot of this, I'll walk through the hall and one of my nurses will say, hey, I know so-and-so, they want to do X, Y, and Z, and I'm able to try to connect them in the right place, or the administrator of the hospital. I think that's another important way of trying to access the system, outside of what I would call the more traditional, you know, ways of doing that. I think is really important. And when you think about too now, healthcare's grown huge, and I think the other thing that is not always thought about, a lot of times, like me today, you think about healthcare and you think IASIS Healthcare. We used to say we were a hospital company, and now we say we're a healthcare services company. But when you think about healthcare broadly, think of all the things that are going on. There's device manufacturers, there's home care, there's physician group practices, there's surgery centers, there's technology companies that have huge needs in healthcare. Cerner, Epic are named. Cerner's out of Kansas City, Epic's out of Madison, Wisconsin. Athena Health. A couple things that have gone on for those of you here in the business school. Again, you know, every physician now is required to use, and every hospital is required to use electronic medical records. I didn't even talk about that today. I would argue that some of the physicians, if we have physicians in the room, would say, hey, that slowed me down. And it did, but what we're trying to do across the country is back to that idea of coordinating care. But technology in healthcare is huge. It's huge. Well, good.
One last question. Last question. Mr. Carl Whitmer, please give him a hand, would you?
Thank you. Thank you, man.
Great job.
Oh, good. Thanks.
Well, we have something for you to recognize your efforts to be here. We appreciate your all time. Please go ahead and open it up.
Oh, okay.
Have a chance to show everyone the great gift you're getting from the Gordon Ford College of Business. I'll remind you that we have
look at that.
A reception at 4:30 at the Alumni Center. This lecture program is made possible by Mr. Hayes Watkins, who is the retired chairman of CSX Railway and a graduate of Western Kentucky University. Right. So please join us, everyone. Mr. Whitmer will be out in front to visit with you a bit. Our reception starts at 4:30, so we have some time for him to meet you. We certainly appreciate the comments. Being on the cutting edge of the healthcare industry, you heard it here. Thank you all for being here. Have a great afternoon. We'll see you at 4:30.
All right. Thank you.
Great job.
Thank
really.
you. I'll turn this off.